محمد غيث from UK. هتكلم على كوريا جرافيدارم او pregnancy induced كوريا. اتفضل يا دكتور محمد.
والله أنا بشكر دكتور زغلول على تقديمه ليا، وبشكر إدارة المؤتمر على دعوتها الكريمة وعلى كل الشغل اللي عملوه عشان يقدروا يتأكدوا إن المؤتمر هيبقى ناجح. So I will start to present. Honorable professors, dear colleagues, first of all, I would like to thank the event organizers for their effort to ensure the success of this event. Also, I would like to thank all my colleagues who are attending this session at the moment. I would like to share this interesting case report with you, a case of Chorea gravidarum. Then we are going to discuss the other differential diagnosis. A 25-year-old lady, gravida 3 para 2, 28 weeks, presented to our maternal unit with a jerky movement of both hands and neck. The patient was conscious all through, but she was feeling stressed. Upon assessment, the blood pressure was 180 over 100, heart rate was 105, and the albumin was +1. The patient laboratory workup was remarkable, but there was no raise in liver enzymes and no drop in platelets. Sorry, I'm having a technical issue. The decision was made by the obstetric team to start magnesium sulfate and to terminate pregnancy, as they discussed that this patient is having eclamptic fit. Despite termination of pregnancy, the jerky movement kept going. The patient was referred to a neurologist who said that this is a Chorea gravidarum. The neurologist started haloperidol for the patient as well as benzodiazepines. 4 days later, the patient recovered completely. Upon asking the patient admitted that she had 2 similar episodes before, and she had 2 abortions with these episodes. Also, the patient admitted positive family history from her maternal side. Full neurological workup was made, and which came back unremarkable. So, what is Chorea gravidarum? Chorea gravidarum is an uncommon movement disorder of pregnancy characterized by involuntary, abrupt, non-rhythmic movement. First reported back in the 19th century and heavily investigated by Wilson and Priest in 1932, who managed to investigate 951 cases. The incidence rate is 1 among 139 deliveries in Western countries. The pathophysiology is still unclear, but there are 2 possible theories. The first possible theory is an autoimmune theory, and it says actually that there is a kind of antibody which attack the neuronal cells at the level of corpus callosum and the level of basal ganglia, and result in a kind of widespread vasculitis. Presumably, after the inflammation resolves, the chorea disappear, and there is a kind of degenerative disease start to happen. The other theory is an hormonal theory, which relies mainly on the level of estrogen. And actually, this was investigated after chorea started to happen in those women who are on OCPs. Another author suggested that estrogen augment the neuronal function by increasing expression of active D5 receptors. Estrogen act as a dopamine agonist on striatal D2 receptor in the medial part of the corpus striatum. In normal estrogen state, this kind of chorea normally doesn't happen. And it was actually that there is a kind of overexpression of receptors in these patients. So what is the possible etiology? First possible etiology is rheumatic fever, including history of Sydenham chorea. Currently, after the treatment of rheumatic fever across the world, half of the cases of Chorea gravidarum is idiopathic. In industrialized nations, systemic lupus erythematosus and antiphospholipid syndrome are the most common identifiable causes of Chorea gravidarum and may be primary or secondary to systemic lupus erythematosus. Other pregnancy-related complications attributed to antiphospholipid syndrome are systemic lupus erythematosus, include spontaneous abortion, PVT, preterm delivery, intrauterine growth retardation, and preeclampsia. The other etiology, which is very rare, but it's very dangerous, and accompanied by lots of complications is Wilson disease. Wilson disease may also include other kind of systemic presentation, such as multi-organ dysfunction, and may present as isolated neuropsychiatric disease. This may be due to drug-induced, especially with the OCPs, as we discussed before, and illicit drugs. What are the clinical presentation of this disease? Chorea present with facial involvement and dysarthria during the second trimester, psychiatric symptoms including personality change, depression, total memories, severe hypnic hallucination, and chronic cognitive deficit. In 2003, there were 2 case reports of cervical dystonia, and 1 case was reported with fatal hypothermia back in 1985. Investigation and workup. The most important investigation that we have to know the reason behind this kind of abnormal movement in order to treat it well. So if we think that the patient is having rheumatic fever should be treated. Treatment can be either in the form of symptomatic treatment of the underlying cause or the treatment of the other symptoms, which can be the cause of the abnormal movement. So symptomatic treatment relies mainly on dopamine receptor antagonists and dopamine depleting agents. Haloperidol has proven efficiency of treating chorea gravidarum based on haloperidol safety profile in the treatment of hyperemesis gravidarum. There is a very low risk of birth deficit. The highest risk of birth deficit occurs if the fetus is exposed during organogenesis. So waiting until the first trimester passed and start to treat the patient. High potency neuroleptics are thought to be safer for the patient. However, data are limited for these newer and neuroleptic drugs. Benzodiazepines may be used for treatment of chorea, but it's advisable to wait until the first trimester before initiating the benzodiazepines, because there is an incidence rate of happening of cleft palate, which is 0.7%. Treatment of possible underlying cause, if there is any kind of systemic lupus erythematosus, like starting steroids, aspirin, and starting to refer this patient to the specialty which we think that may cause this symptoms. Termination of pregnancy was found actually to improve symptoms because we are cutting the circuit of high estrogen and progesterone, which happen throughout the pregnancy. So what is the prognosis and recurrence? If the no etiology is discovered for chorea gravidarum, the prognosis is very good. Recurrence is, there's a very small chance of recurrence with future pregnancy. What are the other differential diagnoses? Other differential diagnoses can be in the form of gestational hypertension, severe hypertensive emergencies. This patient may be on kind of illicit drugs and may be the cause of this kind of abnormal movement, preeclampsia and eclampsia, Sydenham chorea, and Huntington disease. Actually, I would like to allude more about preeclampsia and eclampsia because this was our first diagnosis. So preeclampsia is defined as onset of hypertension with a systolic blood pressure above 140 and diastolic blood pressure above 90 or both, accompanied by one or more of the following features at 20 weeks. The patient may have proteinuria, other organ dysfunction, and uroplacental dysfunction. Eclamptic seizure may accompany the preeclampsia and may follow it. And actually, this is a very dangerous case, as we all know. This slide is showing the strong risk factors and the moderate risk factors of having preeclampsia. We consider the patient having very liable to have preeclampsia if there is one strong risk factor, or very liable to have preeclampsia if there is two moderate risk factors. Angiogenic biomarkers such as placental growth factor and the ratio of soluble FMS like tyrosine kinase to placental growth factor has sensitivity of 80% and negative predictive value of 99.3%. Overall, angiogenic biomarkers can help to rule out preeclampsia and expedite diagnosis of women on preeclampsia. This angiogenic biomarkers has been accepted by the NICE guidelines and actually has been used recently in our trust. There are two risk prediction models which has been used and has came out recently. Both the PrEP-S and the full pairs are being used recently. PrEP-S can be used up to 34 weeks, whereas full pairs can be used at any time during pregnancy. PrEP-S and full pairs are pretty much like other risk models which we use in our daily practice. And in this model, we can see the components of the PrEP-S model, such as gestational age and at diagnosis, systolic blood pressure, diastolic blood pressure, oxygen saturation by pulse oximeter, hemoglobin, platelet count, alanine transaminase, serum uric acid, serum urea, serum creatinine, and urine PCR. In this slide, we can see the full pairs model, which come as a calculator, and it can be done online. So you can just put the gestational age in weeks and days, saturation of the patient, platelets, creatinine, AST, and ALT. Actually, this model is pretty much more diagnostic than the other one. So what is Sydenham chorea? Sydenham chorea was first described by Thomas Sydenham back in 1686. Sydenham chorea is associated with group B strep infection and can follow rheumatic fever by a time up to 7 months. There is an association between Chorea gravidarum and Sydenham chorea. They present either a primary abnormality that may happen, or it may follow in a kind of subclinical damage of basal ganglia. In other words, it may be a true relapse of rheumatic fever. Another author, Maya et al., described that Chorea gravidarum is a frequent complication of pregnancy in patients with previous history of Sydenham chorea, and increased risk of miscarriage should be considered. They favor that the notion that Chorea gravidarum results from hormonal change acting previously on dysfunctional basal ganglia. Sorry, I'm having a technical issue. So the other differential diagnosis is Huntington chorea. Huntington disease and autosomal dominant inherited progressive neurodegenerative disease. It's characterized by chorea, motor disability, psychiatric symptoms, behavior change, and cognitive decline, and may end as having dementia. Huntington disease is a progressive and fatal disorder and hallmarked by generalized chorea. It should be noted that in early course of Huntington disease, the chorea will be very mild and affect, like the patient will be kind of restless. The average age at the onset of the disease is usually between 35 and 45. And it was actually before this era, it was actually uncommon for Huntington chorea to begin during pregnancy. However, the maternal age continued to increase, and that's why we can see Huntington chorea happening in pregnant women. The definitive diagnosis of Huntington disease is by genetic testing. It can be confirmed by seeing a targeted mutation analysis showing CAG trinucleotide expansion of more than 37 repeated. Currently, there is no treatment of Huntington disease, and the only way to treat the patient is symptomatic. The patient should have a multidisciplinary care who can address both physical and psychological needs of such patients. Thank you.
شكرا يا دكتور.
أنا هعمل بس هفتح البرزنتيشن الثانية، فممكن cut off for a second. If there is any questions, I would like to receive them by the end of the session.
المحاضرة الجاية برضو الدكتور محمد هيكلمنا عن pregnant COVID patient.